Ya Allah. Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuhu. This day I will talk to you about epilepsy and seizures. Actually, epilepsy and seizures need more than 3-4 hours to be covered. But I decided to give you only the important informations. So the information I will tell you is fair enough. If you need more information, please turn back to your textbook Davidson. Now, what are seizures? Definition of seizure. Seizures are paroxysmal episodes of brain dysfunction manifested by stereotyped alteration in behavior. What does this mean? There is change in the electricity of the brain, okay? And this change will manifest it in the body by change in the behavior, change in movement, change in level of consciousness, any change in behavior which is transient. Now, clinical manifestation of this alteration in behavior or this change in electricity of the brain depend on region of brain seizing. So, when a focus of seizure origin in the temporal lobe will be different in manifestation from focus developed from the frontal lobe. Causes: primary CNS dysfunction, for example, or metabolic disorders. What we mean by epilepsy? Epilepsy is recurrent and unprovoked seizures. So, you have two or three terms: fit, seizure, and epilepsy. The fit is the episode, first episode, or recurrent episodes. Each episode called fit. When the patient have more than two unprovoked seizure, this is called epilepsy. Seizure is the motor manifestation of it, because we have sensory manifestation of it, and this is usually not called seizures. Cellular definition of seizure is excessive or over-synchronized discharge of cortical neurons. So epilepsy is almost always of cortical origin. It is not a disease of white matter. It is arise from neurons. We have to, regarding physiology or pathophysiology, we have an area or a focus of epilepsy which causes seizure, and this is surrounded by two zones: inhibitory zones, mainly mediated by gamma aminobutyric acid, and an excitatory zone precipitated by NMDA, that is the glutamate. When there is disbalance or imbalance between the inhibitory and excitatory zone, the discharge will spread, and spreading of this discharge will cause this manifestation of seizure. Epidemiologically, approximately 1% population, about 3 million epilepsy cases in the United States. Second most common neurological disease, comparable prevalence in men versus women. This is 1% of population. It means the disease is common. Okay, 1%. About if you took a town with 1 million, then you may have about 1,000 cases. Epilepsy incidence rate by age. You see, epilepsy is a disease of children. Its incidence is increased in children, and we have a second peak after age of 50. And this is apparently clear. This increase up after 50 because of increased incidence of brain disease, like for example demyelination, infection, trauma, tumors, stroke إلى آخره. Any epilepsy in elderly, we should look for an underlying cause. Seizure terms. Please, I wrote you these terms. Please just read them. Ictal means seizure. Post-ictal mean confusion following seizure. Aura is the abnormal sensation preceding loss of consciousness. Automatism, it is a nonsensical involuntary movement. Tonic, contraction producing extension and arcing. Clonic, alternating muscle contraction relaxation. Complex, in partial complex epilepsy, consciousness is impaired, while in simple partial, consciousness is unimpaired. Partial mean focal region involved, while generalized whole brain involved. Convulsion means shaking. Grand mal and petit mal, these are a street term for convulsive and non-convulsive seizure respectively. Now, what are the etiology of epilepsy? There are CNS causes and systemic causes. The most common causes of CNS are head trauma, seizure in the first week of injury, not predictive of epilepsy. If seizure occurs in the first week following an injury, it usually doesn't indicate that the patient will have epilepsy. Second most important cause is stroke. Other causes include vascular malformations, mass, like tumor or abscess, meningitis, encephalitis, congenital malformations, cortical dysplasia, and idiopathic. The systemic causes of epilepsy include hypo and hyperglycemia, hypo and hypernatremia, hypocalcemia, uremia, hepatic encephalopathy, hypoxia, hyperthermia, drug overdose or withdrawal, ethanol withdrawal. Usually seizure occur within 48 hours. Sorry for this pause. Classification of seizure types. Actually, I will tell you about the previous classification, which is outdated but is still valid in most of our books. The new classification, I see it is difficult for you, so please rely on this classification. Usually, epilepsy is classified into partial focal, that is without loss of consciousness, complex partial. Here there is impairment of consciousness, and the generalized type. The partial focal, we have two types. Simple partial mean epilepsy with motor, somatosensory, autonomic or psychological feature without loss of consciousness. Example of motor, for example, jerking of one side of the body, or tonic contraction one side of the body. Somatosensory, for example, pain, electric-like shock, which affect part of the body, mostly hemi. Autonomic, feeling of something epigastric thing, like borborygmi, feeling of tachycardia, bradycardia, feeling of many autonomic features. Psychological also may include elations, depressions, excessive love, sadness. All these occur transiently and without loss of consciousness. In the complex partial, there is also all these manifestations with impairment of consciousness. Actually, complex partial epilepsy include a triad of first aura, following the aura. The aura could be any of the simple partial, that is motor, somatosensory, autonomic, or psychological. Following the aura, the patient will have impairment in the consciousness and plus automatism. You may see a patient smacking his lips or unbuttoning of or retraction of on his clothes. If you talk to him, he may reply or not, and he can act or do some skillful movement during this impairment of consciousness, and he is not aware of it, and he will never remember them. Or the patient may have partial seizure with secondary generalized, that's the epilepsy start focally, involving, for example, jerking of one side, then it will extend to other side, causing loss of consciousness. This is called partial seizure with secondary generalization. Generalized seizure mean if you imagine the brain as a net, you cannot localize at which part of the brain is affected first, but there are many theories. Some say that it starts in the diencephalon, others say it cannot. It is very fast spread to both hemispheres, that we cannot put any focal area, and this includes the absence seizures, the tonic seizure, the clonic, the tonic-clonic, the atonic, and myoclonic seizure, and some of classification put infantile spasm in the list. Now, classification. Partial seizure, that is focal onset, simple partial without impaired consciousness, as I said. Motor symptom, as I said to you, partial seizure have two features. Partial seizure, first focal, there is clear focal onset and there is no loss or without impaired consciousness. Let's talk about the motor symptom, which could be focal motor seizure. It involves motor strip in the brain. You know the motor strip, which is a pre-central gyrus, manifested by abnormal movement of an extremity. Jacksonian march sometimes separate to involve contiguous regions. That is to start, for example, from the feet, extend up to involve the thigh, then involve the upper limb, then the face. This is called Jacksonian march, like a march of the army forces. This is usually followed by paralysis. It's called total paralysis, post-ictal transient hemibody weakness. Somatosensory symptom may involve sensory strip, both central gyrus, temporal, if it occurs in the temporal, hearing and smell or occipital visual lobe. And somatosensory may be in the sensory strip, that's the parietal. Temporal may involve hearing or smell changes, or occipital visual lobe changes. These are somatosensory. Typical feature of these somatosensory is transient. For example, one say that I smell a very bad smell like septic tank, to be followed by other features of temporal lobe epilepsy, or hearing very high sound like the bells of church, and then he lost his consciousness and doing other manifestation of temporal lobe epilepsy. Or the patient just say there is, doctor, there is like an electric feeling of my left side, and this disappear about 1 minute. This is maybe related to a temporal lobe tumors, or parietal lobe tumor, or infarction, etc. Or the patient, if have infarction or tumor in the occipital lobe, he may sustain visual changes like the aura of migraine. Autonomic symptom involve temporal lobe, may lead to tachycardia, pallor, flushing, and sweating. Psychic symptom involve frontal or temporal lobe, called the limbic system. These may include déjà vu, James vu, affective disturbances, cognitive deficit, and hallucinations. All these are transient. You should concentrate. Psychic symptom of continuous, it may mean an underlying psychiatric illness. But in epilepsy, usually they are transient. For example, déjà vu or James vu, déjà vu, feeling that something or some places are familiar to the patient, And James Vu, on the contrary, feeling someone, some own or related things like his house that is strange from him. Affective disturbance may involve excessive elation or excessive sadness, and also the cognitive and hallucination, which may be visual or auditory hallucination. You all know this is the homonucleus, how our body is represented in the brain. You see the face is extensively represented in the brain. The pharynx, the intra-abdominal organs, the teeth, gums, lower limbs, etc. Cortical of the opposite half of the body is similar to that of the motor cortex. This is important to know because if there is a focus abnormal discharge in the area involving this representation, the manifestation will be exactly involving that organ. So classification: partial seizure. Continue. We discussed the partial simplex. Now partial complex impaired consciousness, typically frontal or temporal lobe onset, as I told you, often stereotype for the individual patient. Average duration is 1 to 3 minutes. Simple partial onset can be followed by impaired consciousness. Many times will progress to a generalized seizure, frequently seen adult onset epilepsy. Automatism, that is coordinated involuntary movement, typically oro, bucolingual or non-purposeful hand movement. As a summary, partial complex start with aura. I said to you, aura could be a simple partial epilepsy. Then the patient will pass into a state of impaired consciousness, during which the patient usually do this automatism. Generalized seizure, as I told you, diffuse from the onset involving both hemispheres, and there is usually loss of consciousness. The patient may fall heavily to the ground or may not fall according to the type of seizure. We have the absence seizure, which occur mainly in children, usually lasts 5 to 10 seconds, loss of consciousness without loss of posture tone. Mild head turn or blinking are common. Immediate return of awareness typically resolved by 20 years. This is a very common in children. Usually these cases are referred from teachers in the school. We call them absences because the patient just stare, blanking stares, and then everything settled down in 5 to 10 minutes. The tonic type, arrest of ventilation, can cause sinus. Tonic, that is contraction of the whole body with the arcing, and here the patient will pass in a case, will have a cyanosis. The clonic phase, that is jerking. This is without tonic phase. Sometimes tonic, that is stiffening of the whole body, and then following by jerking with increasing amplitude, and then gradually decreasing the amplitude until the fit is finished. And this is called tonic-clonic. Tonic-clonic is the other name of a grand mal epilepsy. يعني grand mal يعني الأكبر، الصرع الأكبر. Myoclonic is a brief shock-like contraction, may be localized or generalized. Myoclonic contraction of muscle or a group of muscles or the whole body, and usually there is an underlying cause in the brain or spinal cord. Atonic, that is drop, attack, loss of tone, the patient fall to the ground. Myoclonic epilepsy is very common. Juvenile myoclonic epilepsy, from its name, it's usually starts in the young age group, is the commonest of idiopathic generalized epilepsy. Precipitating factors include alcohol, menstruation, and sleep deprivation. The condition is generally linked to short-arm chromosome 6. Prognosis is extremely favorable if the condition is treated correctly, with many patients become seizure-free. Treatment option includes sodium valproate, lamotrigine, and topiramate. Long life treatment is usually necessary to avoid relapses in patients who achieve seizure-free status on medication. Juvenile myoclonic epilepsy, about 16-17 years old, usually occur in the morning, jerking of the upper limbs and head. Is very common and with a good prognosis. Infantile spasm was called West syndrome. It occurs between 3 to 12 months of age, managed by vigabatrin. It is a triad of infantile spasm, a pathognomonic EEG band called Hips arrhythmia, and mental retardation. International definition requires only two of these three elements. Now, what are the pseudo seizures? We talk about seizure. What are about pseudos? These are non-epileptic seizure, maybe manifestation of conversional disorders, factitious disorder, or malingering. Feature that may distinguish from epileptic seizure: first, pre-attack preparation; second, absence of post-ictal confusion; third, disorganized movement, pelvic thrusting, thrashing, bilateral convulsion without loss of consciousness, violent or directed behavior, absence, obscene language. Pseudo seizure, actually, we face them more than the actual seizures. You must be very should be very vigilated and very careful in diagnosing pseudo seizures. Video EEG may be helpful in diagnosis. Seizure phenotypes. Think of anatomy. Actually, this is the Brodmann classification of brain areas. Actually, when we were a student, they taught us epilepsy on anatomical basis, and I see it is very informative. You have to know certain area in the brain, for example, the central sulcus, in front of the central sulcus, the motor area called area 4, and behind it is the somatosensory called area 312, and the somatosensory association area, which is 5, 7, and 40. We have the occipital area, visual area, primary visual area 17, surrounded by the association area 19 and 18. We have visual association area also called 39. We have the Wernicke area, which is important or responsible for reception of language, called Wernicke area, and the primary auditory area in front of Sylvian feature, behind the Sylvian feature in the superior temporal lobe, called primary auditory cortex, which receives the spoken language after it is transferred to the Wernicke area. And we have the Broca's area, which is the executive area of speech, and we have the frontal eye field. Suppose you are knowing all these areas. If you find any focus, for example, in any of these, the manifestation will be very known to you. I will give you examples. If focus occur in the frontal eye field, a Brodmann 8, the lesion will cause deviation of the eyes to the ipsilateral side. Seizure overstimulation, eyes to the contralateral side. So you have two lesions. If a destructive lesion, the eye will deviate to the ipsilateral side, while overstimulation will cause the eye to deviate to the other side. In the prefrontal cortex, called the Brodmann's area 9 to 12 and 46, 47, these areas important for behavior, judgment. So lesion in this area cause deficit in concentration, judgment, and behavior. Lesion, seizure, agitation, and all behavior. I mean, if a lesion I mean destructive lesion, like for example tumors, infection, and inflammation. It's lead to deficit in concentration, judgment, but while overstimulation lead to agitation and odd behavior. Brodmann speech area 44 and 45. Lesion and seizure both cause expressive non-fluent aphasia because it is the area of execution. Primary motor cortex, the Brodmann area 4. If a destructive lesion, contralateral hemiparesis, late manifestation, spasticity. If seizure, there is contralateral twitching, posturing, or convulsion. Now, if we look to seizure according to the lobes of the brain, what are the manifestation of temporal lobe? It is very important actually because temporal lobe epilepsy is very common and surgery is amenable in temporal lobe epilepsy. So it is important to differentiate this type of epilepsy from other. It is the most common amenable to surgery. If you have a lesion in the hippocampal area, cortex, bilateral lesion cause memory dysfunction. This is a destructive lesion, while a seizure usually cause chronic seizure lead to deficit in short-term memory. In Wernicke speech area, Brodmann 22, lesion and seizure, both of them will cause loss of receptive speech and fluent aphasia. In the anterior temporal, bilateral lesions called Clover-Post syndrome, which is very common syndrome in anterior temporal lobe, lead to visual agnosia, hyper orality, hyperphagia, hyperphagia, hypersexuality, and docility. While if a seizure occurring in this area, anterior temporal lobe, patient starting freezing and oral automatism. If a lesion occurs in the primary auditory cortex, that's Brodmann 41 and 42, bilateral lesions usually cause cortical deafness because it is area responsible for hearing. If seizure, the patient will have auditory hallucination. It is very simple to differentiate between lesions and seizures because lesion will lead to loss of function, while seizure will lead to overactivity. For example, an olfactory bulb, Brodmann 34, lesion cause anosmia. خلاص مريض ما يقدر يشتم. But if there is a seizure, olfactory and gustatory hallucination. In the parietal and occipital lobes, in the primary sensory cortex, Brodmann 312, lesion cause contralateral hemianesthesia and astriognosis, while seizure will cause contralateral sensory symptom, that is tingling and heat. So lesion cause negative symptoms, while seizure will cause positive symptom. Occipital lobe, the same. Lesion cause contralateral hemianopsia and macular sparing, while a seizure cause flashing or colored light in contralateral visual field. Now I will talk to you a few notes about epilepsy in pregnancy and breastfeeding. This is a big subject. You need to read about it in your book, but I will tell you the important thing. The risk of uncontrolled epilepsy during pregnancy generally outweigh the risk of medication to the fetus. So hair drug should be continued. Many pregnant women come to us, Doctor, I'm pregnant. Shall I stop my drug? No. The answer is no. Because as I told you, uncontrolled epilepsy is more risky than the medication. There is no point in switching therapies as this could precipitate seizure in an otherwise stable patient. If you faced a lady who is pregnant and come to you during pregnancy, please don't change her therapy. All women should be advised to take folic acid 5 mg per day before pregnancy, and this is to prevent neural tube defect. Lowest rate of major congenital malformation is seen with carbamazepine, lamotrigine, and levetiracetam and levetiracetam. The trade name of it is Keppra. Breastfeeding is acceptable with nearly all anti-epileptic drugs with the exception of barbiturates. Okay, there is a lot of talk about this subject, but please, these are the most important points you have to remember. Clinical cases, these clinical cases, you have to read about it and see the answers. This is an exercise for you. I will not read them. I put to you about 4 cases. You have to read them carefully and give the answer. This is your training. I want an answer from you because I will not send the question for this. This is an exam. What about seizure management? Diagnosis is a clinical history. Diagnosis is a clinical history. I repeat it 3 times because all investigation could be negative in epilepsy. Physical examination, focal deficit, toes paralysis, diagnostic workup, pulse oximetry, glucose, electrolyte, calcium level, CPC, renal function, hepatic function, toxicology screen, ethanol level. Head imaging, which includes CT and MRI, albeit if fever or meningeal sign are present. EEG, confirmation if possible, ictal event or interictal spikes, polyspike discharge, spike wave complex. All these investigation should be ordered for any patient with epilepsy or with fit. Usually we don't treat the first fit. First fit should be investigated. Second fit must be treated. Seizure treatment include acute management and long-term management. In the acute management, 90% of seizures stop without treatment in under 5 minutes. Or you can give lorazepam or diazepam for seizure more than 5 minutes. Monitor the ABCDs, avoid injury and aspiration, treat underlying medical condition. Long-term management include decision if therapy is needed. Seizure due to secondary causes like metabolic disorders or ethanol withdrawals immediately following head trauma or stroke may not need long-term treatment. Single generalized tonic-clonic seizure occur in about 50% of cases. Single generalized tonic-clonic seizure occur in about 50% of the above cases. Anti-epileptic medication. The principles of anti-epileptic medication include the following. First, try to use a single therapy. 2, a second medication if seizure not controlled with single drug and maximal levels or side effects are achieved. Then treat the seizure not drug level. Treat the seizure not drug levels. The anti-epileptic medication include all old agents which are phenytoin, carbamazepine, phenobarbital, brimidone, valproic acid, and ethosuximide. And the newer agents which include lamotrigine, levetiracetam, topiramate, oxcarbazine, and lacosamide and zonisamide. Other treatment options include ketogenic diet in children and surgery. Surgery is reserved for patients with refractory epilepsy. Refractory epilepsy defined as a continuation of fit after using the first choice optimum 2 medication. Mostly for patients with temporal seizure, as I told you, possibility of 70% chance of a cure. If you want more about surgery, please read about it. Surgery may involve lobectomy, like temporal lobe remover, for example, removal of both one hemisphere if it is totally distracted, as in CP or trauma, or callosal hippocampal or callosal sections, or removal of medial temporal part, medial temporal lobe removal, if there is hippocampal sclerosis, or lesionectomy or focusectomy if there is a clear focus on MRI or EEG. And the third option in treatment of epilepsy include vagal nerve stimulation, current given to vagus nerve with theory of decreasing the seizure over time. A treatment of the seizing patient. How we treat a patient is seizing. Yeah, that's you are in the casualty and receive a patient who is still have convulsion. First, ensure airway protection, position to prevent aspiration. Do not place anything in the mouth except when to suction. Do not try to force suction airway through clenched teeth. When the patient stops convulsing, place patient in a lateral decubitus. Begin supplementation of oxygen. This is for for airway protection. Assess safety of patient. Ensure lights in room are on. Remove any object within reach of the patient that could cause injury. Loosen the clothing. Side rails should be up if patient is in bed. Do not try to hold the patient down. Obtain vitals including the pulse oximeter. Obtain and start AQ check. If glucose is important actually for any comatose patient to check glucose, to check oxygen saturation. If the patient have Wernicke encephalopathy, B1 deficiency, or if the patient have if glucose less than 70 mg per deciliter, or if AQ check unobtainable, administer ampoule dextrose 50% not. Ideally 1 mg thiamine IV should be given prior to or soon after glucose. These are the principles, all of you know it. Order diagnostic labs, CPC, CMP, and magnesium, phosphate, toxicology screen, ethanol level, anti-epileptic levels. Most seizures cease without medical intervention, 1 to 3 minutes. Regarding status epilepticus, definition is that the patient continues seizing more than 30 minutes, 2 or more sequential seizure without recovery of full consciousness lasting more than 30 minutes. Types include generalized convulsive seizure. You can see the patient continue in jerking, or non-convulsive status epilepticus, that is absence. Also simple partial status epilepticus. How we treat a patient with status epilepticus? Please start 0.1 mg per kg IV lorazepam. Push at rate of 2 mg per minute can be given IM also. After you finish lorazepam, start phenytoin 20 mg per kg IV. No faster than 50 mg per minute. If the attack or the epilepsy is not stopped, you can start phenytoin directly, or you can give it as a maintenance dose, or force phenytoin to 20 mg per kg IV up to 150 mg per minute can be given IM also. Additional 5 to 10 mg per kg of either can be given. Consider phenobarb 20 mg per kg or valproate 10 to 15 mg per kg IV if seizure continue. If seizure continue, intubation required. General anesthesia titrate to burst suppression, continuous EEG monitoring is required. Phenobarb 5 mg per kg load, 0.5 to 3 mg per kg per hour maintenance. Propofol 1 to 2 mg per kg load over 5 minutes and 2 to 10 mg per kg per hour maintenance, or midazolam 0.2 mg per kg slow IV bolus 0.05 to 0.5 milligram per kg per hour maintenance. You see, it is accepted protocol all over the world to start lorazepam or diazepam. Lorazepam is preferable because of its long acting. You may, if you don't have, you have a four-step: lorazepam, phenytoin, phenobarb, and intubation. If all these measures should be taken in the intensive care, don't forget this. So if you look to this EEG, you find these suppression, see the burst suppression of the wave. So titrate IV agent to burst suppression. That is the patient have no wave at all.